Welcome to part 3 of lumps in lips. In part 1, we discussed how to gather the information you need to make the diagnosis. In part 2, we discussed the main diagnoses you can make that explain lumps in lips after a procedure. And now in this section, we're going to discuss how to manage each one of those problems. By far the most common outcome after a procedure would be bruising or a hematoma. Bruising and hematoma are essentially the same pathological process, but a hematoma is bigger. Bruising we would tend to just leave to recover on its own, but a hematoma might need more management. The first thing is how you communicate to your patient. It's always important that your patient knows what is going on. You should explain the process of developing a hematoma, and you'll be surprised how many people have not considered what a hematoma really is. They associate any bruising with an injury, but they're not quite aware that the fact that a needle going through a blood vessel that then allows the blood vessel to leak blood into the tissue is what a bruise is. So always explain the cause. Secondly is about what you're going to do about that problem. For most hematomas, if they're small and not particularly troublesome, conservative management is a very safe way to go. That is, just allow the lump to recover. It will gradually be reabsorbed by the body, and over a period of up to a month, normally full recovery will occur. There is an option after that of active treatment, and this is for much bigger hematomas that might cause secondary problems, such as infection, possibly necrosis, but that's very, very rare, but certainly pain and a long healing process. So the active treatment you consider is on the mildest end would be just perhaps massaging or squashing a lump so that the surface area relative to tissue increases and absorption might be quicker. This may be painful. The second option is to try and aspirate that lump. Now, aspiration for most hematomas will be difficult because the blood may have clotted, so it is an option to inject with hyalase, which has been done in a few case reports, to dissolve the blood clot and then to aspirate blood out of the tissue. Remember, blood causes inflammation, so the longer a blood is in the tissue, the more inflammation will occur and the greater the healing response. And this is one of the things that can lead to the next problem we'll discuss, which is induration. After you've managed any problem, always remember to reflect on your practice. So think about how to prevent hematomas in the past. Reflect on your injection technique. Are you injecting unnecessarily frequently? Are you injecting too deep? Are you using a needle where a cannula may do the same job better? Think about all you can do to reduce the risk of bruising. Consider also patient selection. Are you treating patients who are on aspirin or clopidogrel or any other blood thinners, or are they people who are older on the spectrum and tend to bruise more often? Sometimes this can inform clinical decision making as you go on to select patients in the future. The next type of lump that is related to hematoma is induration. Induration is essentially an area of healing tissue. There's a fibrous patch of tissue that may feel difficult to discern from other tissue, but it's definitely a lump. Explaining what this is to patients will decrease their anxiety enormously. Remember from our previous lectures that the explanation will involve the fact that they are sensing a knot of tissue and what is causing that tissue to be there. And it's part of the healing process, usually from a hematoma. So you've got extra collagen laid down that will gradually be broken down in time because it's no longer required to stop the bleeding. It happens more after hematomas because of the healing response generated from blood, but time is usually all that's needed. So I would not recommend active treatment, simply reassurance. Also reflect on the fact that you may have the diagnosis wrong. It could be possibly a delayed reaction to the filler, but you'll know that because it won't keep improving. It will actually possibly get worse and feel more lumpy in a week or two's time, and that would require you to review your diagnosis. So give some safety netting, but reassure these will go away on their own, sometimes as long as 6 months after the procedure before they completely disappear. Inflammation is a very common presenting complaint after procedure. Sometimes this can give a sense of lumpiness. Communication in these instances is vital, and usually it occurs in the first 24 to 48 hours. Explain to people why they are having inflammation so that you can give proper reassurance. Inflammation is the body's response to the trauma usually created by the needle as it enters the skin. If there's bruising associated with it, the inflammation will be worse. So give reassurance and then signpost what is likely to happen next, which is that inflammation will gradually subside over a course of up to 5 to 7 days. 90% of people have complete resolution of inflammation. Management is usually conservative, that is, we just watch and wait as the problem solves itself, but it is possible to add active treatment in cases where your patient is distressed, or if it seems like a simple measure to take in order to get a significant improvement. So what I would normally recommend is a non-steroidal anti-inflammatory for people who do not have problems with stomach ulcers or kidney failures or any of the other things that you will see in the literature for non-steroidals. You can also add antihistamines, and in the first 24 hours, a cold compress can be very useful, minimal risk way of reducing swelling. In people who swell significantly and regularly but don't seem to have an ongoing reaction, sometimes it's appropriate to prescribe steroids for a short course. I would use up to 20 milligrams per day, often for just 3 days. Finally, reflect on your practice. What is causing the inflammation? For some people, it's the type of product and they react more to some products rather than others. For others, it's the type of injection or the process that they went through. So if you're injecting multiple times when you could just be injecting 3 to 4 times per side of the lip, that could be associated with why you're getting increased inflammation. And for some people, it's to do with the fact that they have an increase in inflammatory markers in their body anyway from other problems. These tend to more go down the route of acute reaction, or almost like an allergic reaction, rather than what we are mainly focused on here, which is inflammation from the procedure. The next very important possible negative sequelae from a dermal filler injection in the lips is an acute bacterial infection. It's vital in this case to get the diagnosis early so that you can treat, and it's vital to explain to your patient what has happened. So in terms of explanation, we need the patient to know that they have a bacterial infection that may have arisen either from the procedure, from a bug that was near or in their mouth during the procedure that's managed to get in with the injection, or it could have spread from a nearby infection such as a dental infection or tonsillitis. Treatment, it tends to be antibiotics to start with, and ACE guidelines recommend an antibiotic such as clarithromycin at 500 milligrams twice a day for 2 weeks. If this fails, the next step that ACE recommend would be to add a second antibiotic, something like doxycycline, which you'd also use but for a much longer period of time. So up to 4 weeks on a different antibiotics. The final step would be to hyalase the product so that you're dissolving the filler and allowing the immune system to get in and get rid of the bacteria. If things progress even more, it might be necessary that you need to refer your patient for incision and drainage at an A&E department. This is very rare, and if there's any sign that you have spreading bacterial infection in the blood, then IV antibiotics may also be required. It's my personal point of view that waiting so long to hyalase is not in the patient's best interests, and what I currently do with a patient with this symptom would be that I would treat for antibiotics for 1 week, and if I didn't see a really significant improvement, I would hyalase at the 1 week point and continue those antibiotics. I find it incredibly stressful for patients to go through a very long period of taking antibiotics without getting resolution, and for the sake of dissolving the filler and retreating at another point if you so desire, it seems a much quicker way to limit the psychological trauma of having an infection on your face for up to 6 weeks. So my personal protocol would be antibiotics for a week, if no significant resolution, hyalase, and then continuing those antibiotics until complete resolution. The final part with any incident such as this is to reflect on your personal practice. Was there any way that you could have reduced the risk of causing an infection? Are you using a sterile technique? Are you using chlorhexidine or alcohol wipes? Chlorhexidine, by the way, is possibly more effective. Are you injecting very close to the vermilion border, particularly at the oral commissure, where bugs are more likely to enter through saliva from the inside of the mouth, getting onto that part of the skin soon after the procedure? Are you treating patients who are more inclined to have infections because of immunodepression, for either due to illnesses they have or due to drugs that they are taking? And is there anything in your technique that you can do to reduce the risk of infection further? Herpes simplex infection is another common presentation after having a lip treatment. For most patients, they will realize what this is and they don't necessarily seek help. but it might be something that you can react to if they have a second treatment with you to prevent this from occurring each time. If a patient comes with a herpes simplex outbreak and lumpiness around the area, the first thing, as always, is to explain what's going on. The minor trauma caused by the needle has triggered a herpes simplex outbreak. This would be self-limiting, but you can treat it to try and reduce the risk of it becoming more severe. So management, if caught early enough when there are still vesicles present rather than when the cold sore has scabbed over, would be an acyclovir tablet, which are more effective than the creams. You should give reassurance that most will heal within 5 to 7 days with no negative sequelae after that. You may also, as always, reflect on your practice to consider what you could have done to reduce the risk of an outbreak. The first thing would be to give your patient advice on things to avoid that could trigger cold sores, such as their lips becoming dry or having a lot of sun in the period directly after their treatment. Similarly, you may consider your technique as one of the factors that triggers cold sores, and it is theoretically possible that a vermilion border injection might be more likely to cause an outbreak than injections slightly lower in the body of the lip. It's possible that you can reduce the incidence altogether by prophylactically treating patients with acyclovir tablets, and this is something that most practitioners will do if your patient has very regular outbreaks, such as once every 1 to 2 months. Otherwise, you can ask your patient to use acyclovir cream prophylactically immediately after having their lips treated for 3 to 5 days, and that may reduce the risk without the risk of the systemic reactions you can get from oral tablets. And if you look in the BNF, there are lots of possible side effects from taking acyclovir, which you could avoid altogether by using the cream. An acute reaction to dermal filler causing nodules is a very important outcome to diagnose and treat early. The first thing to consider is how you communicate this to your patient, that they have suffered a reaction to the product that is most likely due to their immune system reacting directly to the product that's been injected. However, it is sometimes very difficult to tell the difference between an acute reaction and an infection, and your patient should be aware of this. The biggest difference is likely that an infection tends to be a little bit more isolated and only affect one part of the filler in the beginning, even though it could spread, whereas reactions tend to be more global, and any filler that's similar should be reacting. So explain this to your patient so that they know why you're treating them in a certain way and how that could change if the picture changes. Because there is uncertainty, many people will treat with both steroids and antibiotics in the first instance, just to make sure there's no chance that you are suppressing the body's immune system at the time of fighting an infection, which would obviously make matters worse. So a combination of clarithromycin and prednisolone, 30 milligrams per day, should treat most acute reactions well. If the reaction continues, the next step would be hyalase. Personally, I would be happy to hyalase a patient who is still showing signs of a reaction after 1 week of steroids and antihistamines and antibiotics. This is simply because it's quite traumatic living with an acute reaction. Finally, always reflect on your practice. Was there something you can do to reduce the risk of an acute reaction? Most reactions to dermal fillers happen at the time of either infection in the body generally, or because the immune system is much more active. This can be due to, for example, an allergy to some other allergen, such as hay fever, but anything that is happening that is driving your patient's immune system up should probably tell you to delay the procedure and wait until things have settled. Otherwise, reactions are more likely. The speed of diagnosis is also important. If you leave a reaction for too long, there is a much more of a response by the immune system, and lumpiness tends to last a lot longer. So I've noticed that quick diagnosis tends to lead to quick resolution, whereas the longer the reaction has been happening, the longer it is until they return to a normal state. Chronic reaction, or nodules that come up without much inflammation, are sometimes easy to treat, but sometimes not easy to treat. And it depends on whether they are simply lumps of filler, which should be resolved either with a firm massage or in some rare cases with hyalase, or if they're actually the immune system gradually and slowly reacting to the product over a period of time. The first type of lump is, as I say, just about a firm massage, possibly with hyalase if you cannot do that, but most should be easily rectified with a firm massage. If you have had a chronic reaction, it sometimes creeps up on people because it's very slowly that the filler turns from smooth into slightly lumpy into then nodules, and this sometimes can be 6 months after a procedure. Management of these cases requires, as always, communication to explain what's going on to your patient so that they know the route ahead and exactly what's happened. For many people, they will treat with steroids and antibiotics, but if the reaction has been going on for a long time, a lot of the lump will include connective tissue laid down by the immune system's response to the product. So you don't always get a quick resolution because it isn't just filler that's in the area. It can be white blood cells and collagen laid out around the filler, which take a little bit longer to resolve. We include antibiotics in some cases because it's very hard to tell whether it is a biofilm reaction or just a reaction to the product, so antibiotics are often included to be safe. If lumpiness does not resolve, for most hyaluronic acid dermal filler injections, it's simply required that you reverse the procedure with hyaluronidase, and after a period of 1 to 2 weeks after the hyaluronidase is added, it tends to dissolve the lump and the lump disappears. I believe it takes a bit longer than it does with other lumps because of this immune system reaction that's going on around the filler. So the filler may dissolve quite quickly, but the lumpiness can take a bit longer to go away. If it's a non-hyaluronic acid filler, you can go on down the line of injecting a steroid such as triamcinolone, but it's very rare that you'll have to do that with a hyaluronic acid filler, and this really should be done by a specialist since it is very rare. So in these cases, you might refer to see a dermatologist. Is there anything you can do to reduce the risk of this in your patients? It may be to do with, once again, with illness such as autoimmune disease or allergies. And can you safety net better so that patients come and see you sooner so the problem is easier to solve? It's very important that all patients who have a procedure know that a lump that occurs even 6 months after you've treated them should be treated as early as possible to reduce the length of time it takes to recover. For the variety of presentations that occur after a lip treatment that are neither to do with the product or the procedure, these patients can be managed conservatively. Obviously, they tend to be lumps caused by an ulcer or a Fordyce spot that they've perceived, or sometimes a mucocele. Those, apart from Fordyce spots, which are natural and will be persistent, most of the other presentations recover on their own within 4 to 6 weeks, and simple explanation and reassurance is all that's needed. In case you come across something that might be an oral cancer, it's vital to refer straight to the GP so that they can be dealt with accordingly and given the best care possible, and that you are not responsible for misdiagnosing that lump. I hope this series has given you a great deal more confidence in how to deal with and manage lumps in lips and other presentations after lip augmentation. If you found it useful, please check out the full course, which is called Lip Masters, on the link below.